Hello. Let's see. We'll let people come in. I'll say hello, everybody. If anybody is coming in, we'll wait for a moment and then we will. All right. So hi and welcome. My name is Jada Shapiro. I'm the founder of Boober. We'll talk about that in a moment. We're also very excited to have Jocelyn Wood here today, who is a speech language pathologist, and she's going to tell you all about herself. I'll tell you a little bit in a minute. For those of you coming in, if you want to drop into the chat that we know that you can hear us, that you're here, are you pregnant? Do you have a baby, or are you a care provider? Always kind of interested to see where do you live, and feel free to drop that into the chat. Then we can see that you can hear us. And I'll just wait one more moment. All right, thanks, Jessica. Great. All right, and we will be, okay. So I'll just give it a little start. Welcome, I'm Jada Shapiro, founder of Boober. Boober is a platform where expectant parents and new families can find all of their pregnancy to postpartum care providers, such as birth doulas, postpartum doulas, lactation consultants, mental health therapists, speech soon, we hope, and pelvic floor therapists. We provide childbirth classes, lactation, newborn care, infant CPR and safety, lots of great talks. So a lot of different resources here at Boober. I'm very excited to be speaking today with Jocelyn Wood, who is I'm just going to read your bio if that's okay, and then I'm going to have you jump in. Jocelyn Wood is a bilingual speech pathologist based in Brooklyn. She has experience working with children from birth to 18 years of age with speech and language difficulties. Jocelyn works with families to build natural and fun language learning environments. It also offers workshops for parents to better understand child language development and the importance of vocabulary. So very excited. You also work a lot with, especially the population we're talking about today, this is part of our tongue tie series. And so you're going to be talking about working with new families with newborns or older, depending, right? And let's just hear a little bit first about yourself. If you don't mind, tell us about your practice and you. That'd be great.
Sure. Hi, I am super excited to be here. I think Boober is such a great resource for the community. So it means a lot to me to be able to share with your community and give some information. So as Jada said, I'm Jocelyn. I am a speech language pathologist, and I got my start working in a NICU actually. So I got a lot of hands-on experience dealing with feeding and swallowing. And as I began my own practice, I started seeing more and more children who had tongue and lip tie. So as you may or may not know, providers don't really get a ton of training in tongue and lip ties when they are doing their coursework. So I decided to venture out on my own, and I am actually trained as an orofacial myologist, which is somebody who is specifically trained in the identification and treatment of tongue and lip ties. So I do see a lot of newborns and infants who have tongue and lip ties to see how it affects their ability to breastfeed or bottle feed. And I work with children throughout the lifespan. And I guess we'll get into that a little bit more today.
Definitely we will. It'd probably be good for us to lay the frame of what is a tongue tie in the first place. I think we were doing all of these different tongue tie talks. And of course, a lot of people coming here certainly know what it is, but we're also using this as a resource, this video as well. And so I think it'd be useful just to set the frame a little bit about tongue tie and what that is, if you don't mind.
Sure. Yeah. So I think tongue tie is used globally to refer to all types of oral ties. So there are many different types of ties that you or your baby can have. There is a tongue tie. There's an anterior tie, which would be a piece of tissue that's underneath your tongue that kind of anchors your tongue to the bottom of your mouth. There's also a posterior tie, which is a string of tissue that's going to be further back on your tongue and maybe a little bit more difficult for the eye to see. You can also have a lip tie, which is going to be up here between your two front teeth. You might see a piece of skin that's coming down underneath. And all ties or buckle ties, depending on where in the country you are and how you pronounce it. And those are ties that are in your cheeks, and those can definitely affect your baby's ability to feed. So sometimes a child will have just one of those ties. Sometimes a child will have multiple ties. And I'm saying child, but adults can also have these.
Yes, we've definitely I've seen some people in the lactation world or who've come to lactation over the years start to decide that they want to assess their own situation, oftentimes maybe because their child had a tie, and then they kind of go into their own and decide whether or not to deal with it as an adult. It's really interesting. So we'll talk about that as well. So can you speak a little more about what does being a speech language pathologist really entail, like the scope of how, what you see and how you work?
Okay, so speech language pathologists are really responsible for many different things. They are responsible for speech, which is articulation, how people say their sounds, language, which is how we learn to put sounds together. We also cover feeding and swallowing. And so our conversation today will be more on that feeding and swallowing side of things, but we may also get into talking about speech as well. Articulation development could also be affected by ties.
Okay. So when, well, let's talk a little bit, I guess, one of the big things people really want to understand, right? So if a child or baby has a tongue tie, and I think tongue tie is really controversial right now, first of all, like, and stressful, right? And loaded. There's so much in it when a new family learns or is told that their child may have ankylosing or tongue tie or tethered oral tissues, right? There's so many different terms. And I guess there's the first question is so what? Let's say they have this tissue that you can see. What if it's not affecting their feeding, I mean, I guess that's a lot of people are like, well, I'm feeding fine, even though you see that. So let's talk about that. What does that mean? And what are the potential problems that it could cause? It doesn't always cause issues, right? I mean, I guess that's what I would love for you to talk about.
Yeah, so that's why it's so important to be speaking with somebody who's specifically trained in tongue and lip ties, because many people can have a tongue or a lip tie, especially if you're an adult that went through your entire life with a tongue tie, you know that it doesn't affect you. So then when you're told that your child has a tie, you're like, well, I was fine. I had this tie my entire life and nothing happened. So somebody who is trained in the identification of ties would be able to tell you how that tethered oral tissue, how that tie is affecting function. And when we look at function, we're looking at a few different things. We're looking at feeding, as you said. How is the child breastfeeding or bottle feeding? Are they able to do so efficiently without falling asleep or without losing liquid out of the side of their mouth? We also look at breathing patterns, because a lot of times children who have ties will have an open mouth posture. And although that may not be problematic when your child is a very young child, as they get older, this breathing pattern can cause sinus issues. It can cause enlarged tonsils and adenoids. It can cause reflux issues. And so that's something that you would want to be mindful of, is what does breathing look like when your baby is at a state of rest?
Interesting. And, if, like, I like how you're talking about function. And I think we talk about that a lot when people are, if it's not functionally problematic, like, you're probably not reaching out, actually, honestly, right? At first, like,
Right.
if you can body feed or breastfeed, or bottle feed, and there's no issue, then you're probably not reaching out. So let's talk about the people who are reaching out, because they're often reaching out for help or support. Often first it might be to the lactation consultant, because very commonly it may present as the baby is not able to suck for very long, or they suck for an incredibly long time, or like you said, milk is dribbling out, right? Are there any, so this can be happening. And let's say then that a lactation consultant, they've seen would they make a referral to the SLP or I'm gonna say speech language pathologist, but let's say SLP, right? Would they make a referral to you, and then what would the next steps be? Tell me a little bit about how do you work with families?
Yeah, so that's a great question. I think for many families that are having feeding difficulties, especially with newborns, and they're trying different types of feeding techniques, their first stop is going to be lactation consultant. So they might work with a lactation consultant or an ICBLC, and that professional might make a referral to me if they're noticing that the child is having some oral motor weaknesses or they need some exercises to help to get more function, right? We're always going back to function. And so what an SLP would do is work with the family, maybe also work with the lactation consultant to provide the family with exercises that they can do prior to feeding to help to get some of those movement patterns that the child needs to be a successful feeder.
So you would actually work and instruct the family on some of these exercises that they can do to strengthen the tongue. Would it be to strengthen the cheeks? Can you talk a little bit more about the exercise?
Sure, we do all different types of exercises. They are really specific to each child. So we do sometimes the exercises do have to do with the tongue because we know that our tongue needs to make certain cupping movements in order to be able to successfully feed. If you have a tie, your tongue might be very flat. So we're going to have to do some suck training and some additional strengthening exercises to get the sides of the tongue to lift up a little bit more. For other babies, there might be some issues with the jaw. So the baby needs some jaw stability. And so that might not necessarily be an exercise, but maybe some positioning cues that we can work on with the family to make it a little bit more comfortable and to help to support that jaw, which is where the tongue is anchored, and get some separation between the tongue and the jaw. And then for other kids, we need to work on lip movements. We need to work on getting roundness of the lips. We need to work on training those cheeks to work in conjunction with the lips. And so, depending on where the dysfunction is happening, we would design a treatment protocol that they would be able to use at feeding time.
So how often are you more likely to be referred by a lactation consultant, a pediatrician, a ENT pediatric dentist? I guess do you find that pediatricians are referring to you? I guess that's really my question.
No,
Yeah.
pediatricians, hardly never. I would say I've gotten maybe one or two referrals from a pediatrician, but my primary referral sources are from pediatric dentists, ENTs, and ICBLCs or lactation consultants.
Yeah, that makes sense. I just like spontaneously was like, wait a minute, I'm curious because it seems like, what we find really when there is a tie that it's creating functional issues that the best treatment seems to be when people are all working together, right? That there is the lactation specialty side of things, potentially speech. There is maybe, I'd love to hear, if you work in tandem with other body workers, like craniosacral therapists or chiropractic specialists or PTs. Could you speak a little bit about like the whole kind of village of care around the tongue tie?
Yeah, we really are a team, and I am super lucky in Brooklyn that I have a really strong network of providers. I work on a team with a pediatric dentist. I also work with an amazing ICBLC. We have referrals for craniosacral, which is a treatment to kind of loosen some of the tension that a baby might have with a tie. There's also chiropractic treatment that's available here and physical therapy as well, because one of the things that we see very often in children who have a tongue tie is that they might have a side dominance. So they might prefer one side to the other, and some might also have torticollis. And so it's important to be doing some of this body work or to work in tandem with a physical therapist to really address those issues and make sure that your child is really on the right track.
Yeah. How often do you find that you'll work with a baby and family I guess I want to move into the conversation of whether or not, let's talk about revision, right? Essentially, when somebody does decide to actually revise the frenulum or clip or use laser with an ENT or pediatric dentist, and they actually decide to do that, maybe you can explain that to our audience a little bit more, but I'm wondering, how often would you find that you could work with a baby as a speech language pathologist, where maybe the exercises you do and the positionings you do, they wouldn't need to go on to do the revision? Do you find that that is something that happens, or?
That can definitely happen. We can definitely restore function. I think the biggest thing in working with a newborn and infant population is that time is of the essence. You really want to restore function quickly so that they can get into some normal eating habits. I know many families, my own sister-in-law dealt with this. She was breastfeeding and my niece was losing weight very rapidly, and it was really worrisome. And I think as it goes for a family dynamic and what that does to the feeding relationship, it can be very stressful. And so at 3 weeks postpartum, they decided to have the revision after doing weekly exercises with her. So it really does become a personal issue of how long you want to wait to see if the exercises will help to restore function. But I have definitely had cases where we are able to do exercises, get function, get the child feeding and gaining weight, and then the revision is not necessary.
Yeah. Can you speak to a few of those symptoms? I think that's great to help our audience understand, right? What are some of the symptoms? How do they present where there may be a tongue tie, like you said, like the sudden rapid losing of weight, right? Tell us some more.
Right. And so that's a big one. I think that's the most noticeable one. That's the one that pediatricians are going to notice right away, and go directly to the formula route. But we know that there are other underlying issues that we can look for. There might be some reflux. Mom might develop mastitis at the breast, around the nipple. There will be a lot of soreness. You might have some bruising around the nipple as well. Many times these babies are referred to as being like very colicky and they're making a lot of noise. They're very gassy. And this can be because they're taking in a lot of air because it is so much more effortful for them to feed. Those are really the main ones that I would look for, but there are, of course, some other like little hidden things that you might find.
Yeah, definitely. And so I feel like I'm wondering, do you more often connect with a family after they actually have done the revision? Would you say that's more common than before, or equal, or what would you say?
Yeah, I would say sometimes I do hear from families before they have the revision, somebody who does have a really strong team in place and they want to start doing exercises proactively before revision. What we have found is that families who are doing stretching exercises and who are doing those functional training exercises prior to revision actually have stronger outcomes because what we're doing is we're stretching that fascia that's underneath all that muscle. And that fascia is super thick in the tongue, and it's something that is established in utero. And so the more that we can work that tissue prior to doing the revision, the greater success it will have and the less chance of it kind of like reoccurring or growing back.
Super helpful. Yeah, very helpful to hear that. Thank you. And just as I see a few more people in the room, it's always nice for us to hear who's out here. So feel free to drop into the chat. If you're pregnant or have a baby, or if you're a care provider, would love to hear where you are. Also, just so that people out in the audience, you can feel free to drop questions into the chat or the Q&A, and we'll either, at some point I have a few more questions and then we'll take some questions, but do feel free to, if something comes up, to let us know. So this is an opportunity for you all out there as well. So I would love to ask you the question, what are some of the potential effects, right? Some people feel like, I really don't want to do anything clinical to this tongue right now. I don't want to clip or cut or revise. Some people, may have enough function that they can deal with that, or they make various choices for various reasons. But I think a lot of people probably ask you the question like, well, what if I don't do that? What might some side effects, not that and of course some babies will be fine, and others will have a lot of issues. Can you talk about that range of possible issues if we don't do a revision when there's a real tie there?
Yeah, and you're absolutely right. There's a whole range and whole spectrum of things that may or may not happen. So for some babies, if we just kind of like go across the lifespan, if we decide to not do a revision when the baby is first having feeding issues, and then we get into introducing solid foods, what you might see is some gagging on foods, difficulty lateralizing the tongue, bringing that tongue from side to side, which is really what you need to become a successful eater with solid foods. That's how we get our food back to our teeth. That's how we get a really functional swallow. And I keep saying functional, but it's the truth. Everything needs to kind of work together, and our whole body is trained to work together. And we need our tongue to be able to go backwards instead of forward while we're eating. So that's one major thing that can happen. There can be the gagging and choking issues when transitioning to solid foods. As babies get a little bit older and they start making speech sounds, we may see some distortions on certain speech sounds. So the main ones that are affected are all of the sounds that are produced on the alveolar ridge, which is that little bump that's right behind your teeth. So you might have difficulty with sounds like T, D, N, L, as well as CH and SH.
Okay.
And some kids with a posterior tie might also have a lot of difficulty with R sounds. And those are a little later developing, but if you have a posterior tie, you're not going to be able to retract your tongue the way that you would need to create an R sound.
I'm like doing all of this while you're talking, by the way. I'm making all the sounds, like putting my tongue in all of the spots. So
and then as we also mentioned, oh, sorry.
Go ahead.
The thing that we were talking about earlier is that all of these ties and restrictions can also affect our breathing. And when we have issues with breathing and we have an open mouth posture, you might run into some problems with sleep. Kids who are super wakeful during the night, you might also develop tonsillitis or swelling of the adenoids, as well as allergies, because air is entering through your mouth rather than being filtered through your nose. And so that's another potential side effect of not having a repair.
And when you say open mouth, just for people to understand, is that's really a baby? Can you show it like a little bit open? Like, what does that look like?
So it can be a range. It can be a little bit open. And I'm sure you've seen kids that are like this, but at rest should always be together. Of course, when we're speaking and when we're eating, our lips are open, but an appropriate rest position would look like this.
Right.
And there's no tension on your lips. Your lips are able to stay together without needing to squeeze them together, and they're not kind of falling open.
Interesting. And in terms of, so that's interesting. I mean, I imagine you must get people coming to you then, maybe when they're just first introducing solids. I imagine you get a lot of people, maybe they even stopped body feeding or breastfeeding because it was painful or they had issues and they didn't necessarily get a diagnosis or understand it was related to the tongue. And then they go on to introduce solids, and then the speech comes, right? And at some point there's a realization maybe around speech more, would you say? Is that when you're getting more of the referrals from pediatricians if there's a speech issue? Or still now?
Sometimes I'll get a referral from a pediatrician. A lot of times pediatricians are very focused on language milestones, so they might not even pick up on articulation issues. So sometimes they will make referrals for a child that is really difficult to be understood. A lot of those referrals with speech intelligibility actually come from daycare providers and preschools.
Really interesting.
The people who are around the child most of the day. Yeah.
That's really interesting. So if the child's older, let's say they're daycare age or preschool age, and you first are seeing them, are you immediately often, will you assess like, oh, there is a tethered oral tissue here? Are you able to diagnose? I know our IBCLCs technically can't diagnose. They have to make a referral to an ENT or pediatric dentist for the actual diagnosis, right? But is that in your lane? Can you diagnose?
So I can't diagnose either, but I can strongly suggest that it is there and advise that they go to a pediatric dentist or ENT. So as a speech pathologist, I can assess function. I can say that they have symptoms of a tethered oral tissue, but I would not be able to diagnose the tie.
Okay. And would you say that people at that age, the older children, and are going to get that revision? Is it more challenging getting the revision later? What do you see in terms of the work that you need to do with a patient?
Yeah, so I kind of have a cutoff in my brain of when I like kids to have the revision done. For me, like if you have gotten to 1 year and you've not yet done a revision, it's not going to be the right time to do it. Because your child is so much more aware, it's going to be much more traumatic for them, and you're not going to be able to do the stretching exercises. For children who get referred to me a little bit later for those articulation issues, it really depends on the child. If I see that it's a child that has had a lot of oral trauma or difficulty, reflux caused by the tongue tie, it's probably not going to be a really great candidate for a revision. Just because they've already had so much trauma, it's going to be difficult for us to be doing the speech therapy work if they're so defensive orally. For other kids, we explain what seizure is and they totally okay with it. And so for that, it's usually like 3 or 4 year old. You can have a discussion with them and tell them they'll get this pop afterwards, and it will be an okay experience for them.
Interesting. So getting a little older. Can everybody, I just want to check our sounds.
Yeah, and so once you
one of us is going out. I'm not sure if anybody in the audience can chat or let us know. Are you able to hear Jocelyn in full? She's coming in and out to me. Oh, she just dropped. Okay, we're just going to wait a moment. Does anybody have a question out there right now? I can answer some possible. Oh, she's back. Okay. You're back. We lost you for a second. Okay, let's see.
All right.
All right. You're still a little choppy there for a minute. I'm curious if the audience is, I mean, I heard most of it, but you did go in and out a little. Let me see if you're back now. Okay, let's try. So
all right.
I think what you were saying, but I just want to clarify, were you saying that, okay, thank you. Yeah, they're saying you're coming in a little choppy, but I think let's keep trying. That the child, when they get to be around 4 or 5, they could come back. It's hard between age 1 and 4. Is that what I gathered?
Yeah, toddler ages are super difficult. And one of the reasons why doing a revision or a repair on a 1 to 4-year-old is difficult is because many times after you do the revision, you're going to need to do stretching exercises, and your child is not going to want to do those stretching exercises with you. Once they get a little bit older and they can really conceptualize what's happening and go through the process a little bit, it becomes a little bit easier for them. Of course, it is child dependent. If you have a really flexible 3-year-old and you thought that they would do well with the revision, you would be able to go for it. But in general, like between 1 and 4 is not a great age to revise just because of the oral trauma and being able to really explain it to them well.
And so what would you do in those years?
So in those years, we would just be doing more of those stretching exercises. I'm working with a child right now who is 4, and the family opted not to do any revision. And so we do a course of orofacial myofunctional therapy, which is a form of speech therapy where we strengthen the lips, tongue, and jaw, similar to what we do with babies, but it's more specific to creating speech sounds. And it's more specific to getting that function and getting that movement. And usually, I am able to get children to a point that they can regain function to make sounds. If we do the program and they're not getting any place after 6 weeks, we will make a referral to a pediatric dentist or ENT.
Okay. Right. So you'll be trying working on it, and then we may need to go to the next level and see if we really need to actually do that revision. So in general, if somebody comes, it sounds, like on the earlier side, in the earlier months, it would be easier to do that revision and easier to do the stretching and the work that has to be done, it sounds like, from your perspective.
Yes, absolutely. But you can even have an adult that goes through the revision process and then has to go through functional exercises. And I think, in the scheme of things, it's much more difficult for an adult. And then those toddler age children are kind of like in the middle. They can do it. It will take a little bit longer than an infant or a toddler or somebody who's under 1, but they will be able to really regain function afterwards.
So when you are working, let's go back with a baby, what amount of sessions are we talking about? What is an average? And I'm sure it's different with every family and they have different needs, but let's try if we were really in a newborn who had decided to do the revision, they know they're having issues with feeding, et cetera, and they've made that choice. How many sessions do you think that you would be working with them?
It's usually anywhere between like 3 and 6. So we would do a consultation, really assess where the child is at, I would give some initial exercises for the family to try. Then we would do another follow-up visit to see that everything was working. And then depending on whether or not the family was going to go through with a revision from a dentist or ENT, we follow up exercises and training. Okay. So it would be like 2 visits prior to and another 2 visits after.
Okay. And then, in the pandemic, let's just talk about how you are working right now. Are you doing virtual work, in-person work? What does it look like when you work with a family, or if somebody were to be making a referral in general, to a speech language pathologist? Yeah.
The pandemic has been very interesting, I'm sure, for everybody, but especially for people who work within your mouth. It's been very interesting. So my practice was only virtual, and within the past month, I've started to offer more in-home visits depending on the comfortability of families. So we've been super flexible. We've been working outside in courtyards with little space heaters. We have been working socially distantly within homes, and we've also been working virtually, which has actually been really nice because I can get really close up to the child and see exactly what's happening and really observe what the real life interactions are between families without having like that extra body in the room that interferes with the most realistic environment.
Yeah, it is really interesting working virtually, even when I'm teaching, or I'll mention tongue tie and I'll show my own frenulum right up to the camera, right? Because you can really have these moments or working with families, but it's interesting. And does insurance cover the work that you do, or any SLPs?
Good question. So speech therapy is something that is covered by insurance. I do not accept insurance. I think most SLPs do not accept medical insurance, but we do provide out-of-network invoicing, which means that families are able to send their invoices to their insurance company for reimbursement. Tongue tie is a code that is able to be reimbursed. And we would go that route. I don't actually know any speech pathologists in Brooklyn who are accepting medical insurance.
Yeah, it is definitely tricky, but you will provide that super bill or
Yeah.
coding. Okay. And in terms of, a family that's bottle feeding, I think a lot of people don't realize that ties can affect bottle feeding. Can you just speak to that a little bit? How would a solely bottle feeding family also maybe note that there's some kind of issue?
Right. So the same issues that we were talking about with breast and chest feeding may also happen with bottle feeding. So what you might see is that the child is losing a lot of liquid out of the side of the mouth. They're not using all of that lip function to pull from the bottle. Their tongue does not have to get as round. And so they might still like passively be able to get liquid out of the nipple of the bottle by pushing up against it. But what you might notice with that baby, they fall asleep during feeding, they become physically exhausted from eating from the bottle, or they can't increase the amount of food that they're feeding. So I had done a consult last week on a 2-month-old baby that is kind of like stuck at the 2-ounce level. He can't increase the amount that he's eating because he becomes so physically tired when he's eating from the bottle.
Interesting. So what are you doing with this child now? Like, if you can, I think that would be interesting to hear. Like, okay, so you have a 2-month-old coming in and they're having issues at the, like, what does your assessment look like? What are you doing?
So that baby actually had a tongue tie revision at 2 weeks. And so the family is now going for body work because one of the issues that's happening with that child is that there are still a lot of restrictions, especially in the neck, that are preventing him from getting the full range of motion. So they have exercises and positioning from me. I had made some positioning suggestions to make his neck a little bit more in alignment so that he's not really straining on his neck and going backwards. And they're also doing some body work with a craniosacral therapist to really help to get him back in alignment and help to make that feeding a little bit easier.
Oops. Just lost you for a second after alignment. I wonder if, I don't know, maybe turning off the camera for a minute might save your bandwidth.
Sure.
Let's see if that helps a
There
little
I am.
bit. All right, cool. So you were saying they were seeing chiropractor as well.
Right. So they had gone to see a craniosacral therapist to do some of that body work. And they're also doing positioning exercises and strengthening exercises that I had provided to them to help to increase the child's amount to 4 ounces is the goal right now.
All right. We actually have a question from the audience, so I actually want to make sure that we get this. In terms of treating lip tie, who do you feel is best? There's a lot of conversation around this, but in your opinion, ENT or pediatric dentist is the question.
Okay, so I think the most important thing is just to find somebody who is a preferred provider, meaning it is somebody who has specific training. And depending on where exactly you are, you may have a ton of options. You may have a dentist or an ENT who they're both trained in being able to do the revision. I personally go with the pediatric dentist over the ENT. No specific reason, but I do feel like because pediatric dentist would be the person to treat the tie as the child becomes older, you want that continuum of care. So if the child has to go back in the future, the pediatric dentist is going to be the one who deals with that after a certain age. And it does affect how your teeth come in. So they would be really mindful of making sure that the release is done in such a way that the teeth are able to grow in naturally.
Yeah, that makes a lot of sense. And I think there are those issues where we've seen somebody get a revision from somebody who doesn't really specifically specialize in babies or newborns or child and feeding and all of the whole issues, right? And we've definitely, I think a lot of practitioners have seen that. And that's why I think like what you said really finding that person who is known to be reputationally like really great at what they do, ideally, because it is tricky. And I know it's hard to find. And in New York, we obviously have more resources where we are based, although still maybe not as many people focused in on this, but very important.
Yeah. And so that's kind of like the guiding thing. I've heard horror stories of people that just go to any old dentist to do the revision, and their children are in a lot of pain, or there's just poor post-op care. And I think that it makes parents more worried about a procedure that, if it's done by a professional, is actually something that's very quick and will not be very painful to your child.
Right. It seems like, the professionals that really have a whole aftercare protocol, right? They're talking to you and they're going to lead you in the before care and the aftercare protocol. And especially if the babies are younger, and especially if you are nursing your baby, that they're a practitioner who can really speak to the newborn experience and understand that you probably do need more lactation support after, because there's the post exercises. And then there's the baby getting used to feeding now in a different way, right? I mean, you
Right.
must work with the babies who are really relearning their tongue.
Yeah. And so if you have a baby who, like I said, he was 2 weeks old when he was revised, we learn our tongue function when we are in utero. So even though the baby has only been out for 2 weeks, he's had 9 months plus 2 weeks of that tongue function that we do need to retrain. And so that post-op care and that retraining of the muscles is so important.
Yeah, definitely. So any other kind of thoughts that you want to share just from your practice? Actually, first, let me just make sure we drop your handle. What's your IG handle?
It's Speech with JWO.
Speech with JWO. Oh, is that
JWO. Yeah.
Nice. So you can definitely follow at Speech with JWO, and follow us if you're not on Instagram at Get Boober. Just wanted to put that there so you can get in touch. But yeah, what else would you, any kind of just last things that you would share about, about your profession, about what you do, about tongue tie in general? Just like, imagine
Yeah.
whoever, tell us.
So I love that tongue tie is getting so much attention right now. I know that it's super controversial, but I kind of love that people are getting interested in it and having conversations about it, because I do feel like identifying some of the issues that can happen in a newborn baby, in an infant, in a toddler, being able to identify those issues and find a team that's able to support you is going to be so helpful to you and your family. It's going to help you to really establish those strong foundations and ties that you want at mealtime and at feeding time. You don't want stressful meal times. You want happy, good feelings. And I think if you are addressing these issues and you're finding the appropriate support with people who are appropriately trained, you're going to have much more successful relationships around mealtime. You're also going to be more empowered to make the decisions that you need to make to help your family really thrive.
Yeah, thank you. And I actually have one more question that came from what you just said. And I was thinking, that you brought up before about one of the symptoms or side of, I guess, symptoms, let's say, right? Gagging, choking when you first introduce the solid foods. How would a parent know that it's like more serious? It's not just, a lot of babies at first reject. We do an infant solids class here for people introducing solids. And certainly babies, when they first taste a new food, they'll sometimes kind of, be like, what is that?
Mm-hmm.
If they don't love it at first, which is different. So every time the baby really will be having these kind of gagging, choking issues, I presume. Can you talk a little bit about that?
Yeah. So just because a child who has a tie, when they're eating, their tongue is not going to be going from side to side. So what you're going to see, and as you said, new solid eaters will do this. They'll kind of suck food off the spoon and use their tongue a little bit back and forth like a iguana and try to pull it back, and that might cause some gagging, or having that new sensation of food in their throat that they're not really used to. But for somebody who has been spoon feeding for a few weeks and they are still gagging and choking, it would be useful, especially if if a child has any choking incidents at all. It would be really important to work with a swallowing specialist, not necessarily a speech pathologist. There are also occupational therapists that work with feeding and swallowing and choking, but it would be super important if there was any incidents of choking to work with a specialist.
Right. That makes a lot of sense. So like really clear on that. And also, we do an infant CPR and safety class here, which is especially important, when you are introducing solids. I think if you haven't taken it already by then, it's a really good time to become very familiar with how to protect or respond to a choking incident. We have another question, actually. So how can I minimize the jerking back of the neck when baby is trying to latch because of lip tie? Would I need to seek a therapist for this? And Court, can you tell us how old your baby is? That would help us too. But if you have anything you want to speak to on that, feel free.
Yeah, there's definitely, okay, 2 months old. There's definitely some positioning that you can do to minimize that jerk. I often find that a side lying position is really helpful for babies who are jerking back, just because you can keep them really straight in alignment with the nipple. There are also some chin tucks that you can do, but if you are concerned and you are seeing these types of issues at 2 months, it might be helpful to speak to a specialist.
Yeah, I do. I want to hop in on that too. Like if every time, it's hard to know again through chat here, Court, but we will certainly try if you're seeing every time this kind of, latching back, and you're saying because of lip tie. So I guess we're wondering, in terms of the lip tie, do you see like are the lips quivering when the baby is latching always, right? There's some signs where it's hard for the baby to latch, or they lose that strength, is challenging because they're gripping. Are there any other issues that you're having, Court, that you feel like sharing? Because if it is continuing on for this long, then it may really behoove you to get seen by a lactation specialist first, and then possibly, a therapist as well.
Every time. Yeah.
Yeah.
Yes, I would say the best course of action, as Jada is saying, is to definitely reach out to some type of lactation specialist so that they can help you work through it a little bit and establish some better feeding habits.
Yeah, the head quivers, not the lips. Okay. Have you seen anybody yet for anything? I mean, is baby gaining weight okay? Like you've gotten this far. I'm just curious. Are you? And I know it's a little challenging in this format. I will also, Court, just in case, I'll drop our, in case you want to fill out a form, we can call you and talk to you a little bit, get a little more sense of what's going on, and then see if there's an appropriate person to match you to. But yeah, that would be one of the questions we'd ask. Weight gain is okay, which still doesn't necessarily, right?
Yeah.
Mean that you're not having an issue. Like we want to trust that if you feel like something's not quite right, you're welcome. Yeah, definitely. We'd love to try and help support you there. All right. So yeah. Any other parting thoughts? This has been really interesting. Thank you, Jocelyn, just to kind of hear overall and understand, because I think a lot of people don't realize that the SLP can be part of this team, really, in terms of helping support, babies that are struggling with some ties, or on all of the various ties, not tongue or lip or buccal or buccal, depending where you are.
Yeah, and no, this is great. I love being part of a team. I love, this whole team-based approach, because that's when you are going to see the most growth and the most changes. I think letting parents know that SLPs can be a really integral part of your feeding team with your young babies. A lot of times when I tell people that I work with newborn babies, they're like, but you're a speech therapist. How do you teach a newborn to speak? And I'm like, yes, it's much deeper than that. We start from the ground up and we build those solid foundations.
Totally. I'm just going to throw up this poll real quick for the people who are here. We'd love, it helps us know just who came by and what other things you might want to learn about. So if you don't mind just filling that out while you're here, guys, if you can see that, that's super helpful to us. Helps us figure out what other webinars to talk about and other topics. And Jocelyn, really appreciate that you taking the time to spend some time with us and fill us in. And glad you are out there working with all the babies and the kiddos, and I guess some adults, the whole range, right? You can see everybody. So if anybody, we're hoping we will soon have maybe hopefully you and some, on our platform. But at the moment, you can reach Jocelyn. You want to drop your website, or actually I have it, or if you want to type it out, if you don't mind.
I will put that in there.
Hopefully you can follow
so you can
us.
go.
Yeah, you can go there, follow us on Instagram, as you saw. And all right. Any other questions before we head out? Anybody else out there who has a question?
Okay.
All right.
Thank you.
Thank you so much. And I will see you soon.
Okay, great.
There, everybody. Thanks so much for coming. Thank you. Thanks, Bettina. Thanks, Court. Thanks for filling this out, you guys. I appreciate that. All right. Well, have a great night. And let you log out.